In the next 20 minutes, we will discuss next-generation imaging in the management of advanced prostate cancer. These are my disclosures. I'm going to show you that bone scans and CT scans remain at the center of clinical management of men with very high risk and locally advanced prostate cancer because of their proven prognostic and predictive roles in directing patient care. The framing for next-generation imaging is therefore a problem solver after conventional imaging because immediate use can often confuse management. We need to acknowledge that high-quality evidence on management and patient outcomes is needed if there's going to be a full substitution of bone scans and CT scans by next-generation imaging. Our focus will be on locally advanced prostate cancer, which is T3 or T4 disease, but with or without clinically positive pelvic lymph nodes. We know that high-risk and very high-risk diseases account for about 20% of all the presentations. Yet over the next 10 years, it accounts for almost 2/3 of the prostate cancer mortality. We need to remember that the proportion of these high-risk presentations is very much dependent on geography. Now, there's a spectrum of diseases for high-risk, locally advanced prostate cancer ranging from the best prognosis with pelvis only or without nodal disease to the situation to where you may have low volume or high volume synchronous metastases on bone and CT scans, which has a worsening prognosis. So here's an example of a man with high risk, locally advanced prostate cancer that is confined to the pelvis without metastases. In another patient with more advanced cancer, in this particular instance, on the MRI and the PSMA PET-CT scan, we see a bone deposit. Of course, the worst prognosis is the patient like this, where we have a locally advanced prostate cancer with bone deposits. So how should we manage patients with very high risk, localized and locally advanced cancers at presentation? Regarding the imaging strategy, the ASCO 2020 guidelines are pretty clear that if you have a positive result with conventional imaging, which we've said is bone and CT scans and morphological MRI, then there is no compelling reason to perform next generation imaging, and you can proceed to treatment as you might otherwise. It's only for those men with negative or equivocal results that you may consider using next generation imaging if it will potentially alter management. Now, here is an example. This is a young man, 55 years old, very, very fit, has a normal PSA, but high-risk disease with T3A disease and a Gleason 9 tumor. We can see 2 bone scan abnormalities, both of which are negative on the CT scan. So this is unconfirmed, likely metastatic disease, but the CT scan is negative. We did a PSMA PET-CT scan and a whole-body MRI scan on this patient. And what we see is that both the pelvis and rib lesions are positive on both the PSMA and WB MRI scans. So when you look at this guy in total, we have 2 to 3 lesions on the bone scan, nothing on the CT scans, 10 lesions on the WB MRI, and 10 lesions on the PET scans. So we have clarity on the tumor load. On next generation imaging, we have polymetastatic disease, and on conventional imaging, we have oligometastases. But how does this information impact management? Management is determined by risk categories defined by the appearance of bone and CT scans. The most common definitions used are the charted and the stampede definitions. For example, in the charted definition, more than 4 bone deposits or visceral disease defines high volume diseases. So if you look at the left-hand side, you can see that patients with low volume disease are often treated with double treatment, ADT plus an androgen receptor pathway inhibitor. There may be a role for chemotherapy in some patients, but you would consider pelvic radiotherapy with radical intent and osteoporosis prevention. However, with high volume disease, you will try to use docetaxel chemotherapy up front with the androgen receptor pathway inhibitor. In other words, a triplet, although some people would be suitable for a doublet treatment. Remember that radiotherapy to the pelvis is with palliative intent and high volume, and that the dosing of bisphosphonates is different between low and high volume diseases with osteoporosis prevention and bone protection indications. How often do we see changes in the volume and risk of disease when comparing conventional imaging with PSMA PET-CT scans? Well, if you look at the arrow, we can see that out of the 50 patients with low volume disease, 11 were up-risked based on a PSMA PET-CT scan. That's about 22%. So looking at the patient we were discussing, remember he had oligometastatic disease on conventional imaging and polymetastatic disease on next generation imaging. So what can we say about his pelvic treatment? Can he have surgery because that was the initial plan? The answer is no, because he has polymetastatic disease. So probably he should have pelvic radiotherapy, but with what intent? Radical or palliative, and bisphosphonate use. What dosing? These decisions depend on the assumption that the prognosis of CT occult disease is the same as CT visible disease. Is this true? Well, this was looked at recently in this abstract at ASCO 2024. Interestingly, you'll see in a multivariable analysis that patients with PSMA positive and CT negative lesions represent a different prognosis. These patients have better outcomes, so they have lower rates of PSA progression and a longer time to castration resistance compared to patients who are PSMA positive and CT positive, so they do not have the same prognosis. So these lesions may indicate earlier stage disease or even dormancy. The uncertainty about the progression rate necessitates careful consideration of the potential benefits and risks of treatment compared to CT visible disease, which in fact has a worse prognosis due to the established presence of the vicious cycle of bone metastasis. So when we see data like this and are told that 28% of patients using the PSMA approach experience a management impact versus 15% of patients using the conventional approach, we really have to ask the question, are these added treatments in fact over-treatment? So looking at the bigger context, we can say that next generation imaging can cause stage and risk migrations, which can result in treatment intensifications or denials. With increased sensitivity, you've increased the risk of exposure to systemic therapies for patients who might not benefit. On the other hand, you may deny local radiotherapy, which might be beneficial. However, increased specificity tends to push it the other way. When you look at the ProPSMA study, you find increased sensitivity and specificity with PSMA. Still, sensitivity increases predominating over specificity increases, which is why there is a strong recommendation for the use of PSMA for high-risk local advanced prostate cancer in the 2024 EAU guidelines. However, at the same time, the guideline states that the ideal management of patients diagnosed as metastatic by these more sensitive PET-CT scans remains unknown. So we've clearly highlighted several challenges and unanswered questions. There's a lack of evidence for improved survival. There is uncertainty about the prognosis for next-generation imaging-only detected deposits. There is a dilemma in treatment selections. There's a potential for overtreatment, and we know that next-generation imaging is more expensive than conventional imaging. This is why we need randomized control trials that will test the clinical utility of these techniques compared to conventional imaging. And this is one such trial, the Avidity trial, which has yet to start. It is a randomized control study to assess the clinical utility of PSMA PET-CT scan in newly diagnosed high-risk prostate cancer. So, pending the emergence of more definitive data, what can we do today for men with very high-risk locally advanced prostate cancer? The current recommendation is to still go with conventional imaging, such as bone scans and CT scans. However, we use whole-body MRI, WBMRI, which is a bridging technology between conventional imaging and PSMA PET scans. If these conventional images show positive results regarding the volume and distribution of the disease, then there is no compelling reason for a PSMA CT scan, and you can proceed to systemic therapies, including pelvic radiotherapy, for local tumor control. On the other hand, if you have negative, equivocal, or oligometastatic disease on conventional imaging, you may want to consider PSMA PET-CT if the prognosis or management would be altered. For example, if you're going to use surgery with pelvic nodal dissections, then PSMA would be justifiable to expand the surgical field. Suppose you were going to opt for radiotherapy with radical intent. In that case, you might do PSMA CT scans to look for involved nodes or oligometastases for future boost radiotherapy in case of a good PSA response to neoadjuvant treatment. PSMA PET would also be justifiable in improving confidence and limiting the duration of adjuvant hormonal treatments. Here's an example of a 60-year-old man with locally advanced prostate cancer with pelvic nodes and low-volume metastatic bone disease. It's quite clear what we need to do here. He needs neoadjuvant ADT, docetaxel, and ARPI, a triplet, or ADT and ARPI, a doublet, followed by prostate radiotherapy with curative intent, followed by pelvic nodal radiotherapy and boost radiotherapy to any residual nodal disease or oligometastatic disease if he has a good PSA response, followed by adjuvant abiraterone or ARSI for 2 years. He had a doublet therapy followed by prostate cancer pelvis radiotherapy with a boost to the residual nodal disease and the oligometastatic lesion in the right iliac bone. So here are my takeaways. The main point is not to find more, but to find what's important. High sensitivity has an unproven potential to change the disease course and improve outcomes. However, we need to be aware of biases, including stage, grade, and risk migrations, together with length and lead time survival biases. We recommend using PSMA PET-CT to clarify the nature of uncertain CT or bone scan lesions if the prognosis or management would be changed. The net clinical benefit of therapy changes is currently unknown. Therapy escalations are less likely to be harmful because of the good rule inability. Treatment de-escalations have to be done cautiously because of the moderate rule-out ability. The ability to detect and treat microscopic metastatic disease may not alter the clinical risk-to-benefit ratio. Prospective studies deploying modern imaging and treatments are needed. I hope you found some of this discussion useful as you think about how you might use next-generation imaging for the treatment of men with locally advanced prostate cancer in your practice. Thank you very much for listening.